Another sort of a neglected disease over here in Sri Lanka, and it's all about pulmonary hypertension and the recent developments in the management of it. This will be delivered as a plenary by Dr. Rachel Cordina, and the chairpersons for this session would be Dr. P. Sadanandan and Dr. Mervyn Fernando, Senior Consultant Cardiologist.
Good morning. My task is to introduce our next speaker with a very illustrative career, who is from Australia, all the way from Australia, Professor Rachel Cordina. She obtained her primary degree in 2002 and obtained FRACP 2009, PHD in 2013, and she is has a sort of very interest in research and development in the structural heart diseases mainly, and with many awards. Without taking much time, we'll invite Professor Rachel Cordina to deliver her lecture. Thank you.
Hello, thank you very much for having me today. It's a real honour to have been invited to speak at your meeting. So I've been invited to talk to you today about recent developments in pulmonary arterial hypertension, and these are my disclosures. So mainly in my talk, I'm going to be focusing on Group 1 pulmonary arterial hypertension, and they're the group idiopathic, heritable, drug and toxin associated, connective tissue disease associated most commonly. But there are also some rarer causes, including congenital heart disease, which is my main area of practice. I'll touch very briefly on left heart disease at the end of my talk, but really all the data I'm going to be speaking about are Group 1 pulmonary arterial hypertension. And for those of you who work in the area, I'd really encourage you to have a look at the guidelines that have recently been updated from Europe, which are really excellent, with fantastic guidelines for all of us, and very simple as well. So historically, pulmonary hypertension is a progressive disease with a terrible prognosis, but that landscape has changed dramatically, particularly in the last 5 to 10 years, where we've recognised that if we detect the disease early, we can really modify the course and patients can be stabilised in the long term. Of course, if we pick up the disease later, we won't always make up ground that we could have if we detected it earlier. I've just taken this algorithm from one of the guidelines, and I just want to demonstrate to you how important risk assessments become in all of our treatment pathways. So I want to focus on the non-reactive group here for a moment. And you can see that the first thing we do when we meet a patient is we need to think, are they low, intermediate or high risk? Because it really determines which pathway we're going to put them on for management. If somebody is high risk, there is good evidence to suggest that we really need to have a low threshold to put those people on long-term intravenous prostacyclin therapy, because it remains the only drug with mortality benefit. All the other drugs I'm going to speak to you about today have mortality included as a combined clinical endpoint. And the strongest data for those high risk is long-term intravenous prostacyclin therapy. But in those who are low or intermediate risk, we have oral therapies that we can offer them. So when I'm talking about risk, what exactly do I mean by that? And the registry data have really provided an enormous amount of information in recent years. And you can see there's a whole bunch of things that won't be surprising to you as an experienced clinician that are important contributors to risk: functional class, 6-minute walk distance, BNP or neurohormonal activation, poor hemodynamics like high right atrial pressure or low cardiac index. But there's a number of simplified tools now. This one is from the European guidelines. It's very simple and it's well validated. There's also some online risk tools. The Reveal Lite is a nice, simple tool that you can use simply in clinical practice. And there's some calculators for you online as well. And you can see low risk as a functional class 1 or 2, walk distance above 440 metres, and a low BNP, and then worsening from there into the intermediate and high risk groups. Now, not surprisingly, the outcomes are dramatically different according to risk stratification, with 5-year survival at 92% in low risk patients and 6% in high risk patients. And we really can get patients into that low risk class with aggressive treatment. Not all patients, but it's been remarkable watching how many more patients we can get into that low risk category with more drugs available to offer to patients and attacking the pathophysiological pathway from different angles. So as I said, we're really trying to get our patients into this low risk group with no signs of right heart failure, no progressive symptoms, good functional class, low BNP, reassuring echo appearances, and if we've repeated a right heart study, reassuring hemodynamics. Now, this must be one of the most used figures in the world of pulmonary hypertension, but it demonstrates beautifully the most common pathways that we attack with our therapies for pulmonary hypertension. The endothelin pathway. Endothelin is one of the most powerful vasoconstrictors known to man. And by interrupting that pathway at receptor level with our endothelin receptor blockers, we've been able to really modify the disease process and improve clinical outcomes. Nitric oxide is not just a vasodilator, but it's also important at maintaining the health of the pulmonary vasculature and maintaining that balance between proliferation and anti-proliferation, and similarly the prostacyclin pathway. There is still a role, even though I've said we like to attack the disease at all angles, there's still a role in a number of patients, a smaller number of patients, for monotherapy. We no longer do vasoreactivity testing on every pulmonary hypertension patient that comes to the lab, but it is very important in people who have idiopathic, heritable or drug-induced pulmonary hypertension, because a subset, around 5 to 10%, will be vasoreactive, and some of those will be long-term calcium channel blocker responsive. And when they're responsive, it's really quite a dramatic response. And those patients perhaps even have a different type of disease than those with other types of pulmonary hypertension. But if you are maintaining somebody on calcium channel blockers, it's important to repeat your catheterization and ensure that there's not progressive disease that you could be intervening upon with other drug pathways. There's also the long-term patients that you've been looking after for years and years before we had evidence to support multiple drugs. And if somebody's stable and maintained in a low risk category on one agent, then there's no need to change them across. People who have risk factors for left heart disease or have left heart disease, we need to be cautious with, because we can precipitate pulmonary edema if we're overly aggressive with our pulmonary hypertension medications. And people who have pulmonary veno-occlusive disease may also develop pulmonary edema when we use our pulmonary vasodilator medications, and they can be a very tricky group to manage. Occasionally, we'll pick up a patient very early with mild disease, and again, we may just maintain them and watch very, very closely on one agent with a low threshold to escalate to 2 drugs. So the Ambition study was published back in 2015 and was really a massive development in pulmonary hypertension, a really well-designed study supporting the use of upfront combination therapy with an endothelin receptor antagonist and a phosphodiesterase inhibitor. And this has really been incorporated into international clinical guidelines, and is the standard of care now in most countries who can access the drugs. So the Ambition study showed a very large 50% hazard ratio reduction. And you can see here, this graph has been shown many, many times, demonstrating the important improvement. Now, as I said again, it's a combined clinical endpoint. They were unable, and they weren't designed to just study mortality. They used a combined clinical endpoint. And then along came Selexipag, which was another really important development. So up until very recently, we'd only been able to administer prostacyclins through a drip, as an inhaler, or subcutaneously, and it's really been very inconvenient and difficult for many patients to be maintained like that in the long term. And Selexipag enables us to activate that receptor with a drug, which was a major advancement. And the data were really exciting for Selexipag as well. 30% relative risk reduction in time to first death or hospitalisation, 40% relative risk reduction in morbidity and mortality, even when patients were already on 2 drugs at the beginning of the study. The downside is that the dosing is a little bit complicated, but once you've done it once or twice, it's really not that hard. But it does take a bit of fiddling around, and I'll explain that to you in a minute. There's been, these are the 2 most important Selexipag trials. Griffin, which was the largest, which studied Selexipag introduced as a second therapy or as a third oral therapy. Whereas Triton studied a smaller group who were on Selexipag up front in triple combination therapy. And both trials demonstrated important benefits in their combined clinical endpoint with very similar risk reduction of around 40%. This is Griffin. And you can see there across all the pre-specified subgroups, essentially different pulmonary hypertension types, sex. Younger people benefited a little more obviously, which is not surprising. And Triton here again, very similar risk reduction with triple therapy that included Selexipag. There are some side effects, not surprisingly, if it's triggering the prostacyclin receptor. Headache is fairly common. It can generally be managed with paracetamol, and tolerance does develop over time and it becomes less prominent. Diarrhea and gastrointestinal upset's quite common. It's more common than we see with the other oral drugs that we use, as is pain in the jaw, especially with eating. And any of you who have used intravenous prostacyclin will know all these symptoms are very typical of prostacyclin medications. When we first started using Selexipag, there was a warning in Europe, and everybody was very worried because there were some deaths associated with the use. But when it was examined in detail, it was recognised that Selexipag had been used in high-risk patients who really should have gone straight onto intravenous prostacyclin. So the role of Selexipag is not to be used in people who are very high risk. They need to have prostacyclin intravenously and be referred for transplant. It's in people who after 3 or 6 months of 2 agents are only intermediate risk, that we've not gotten them into our low risk, and then we'll add that in as a third agent. Of course, from time to time, you'll have somebody who you're really worried about who just will not have intravenous prostacyclin therapy, and on a case-by-case basis, we may introduce Selexipag in that situation, being very open with the patient that it's not the best therapy and that intravenous prostacyclin would be preferable. When we start Selexipag, we start at a low dose of 200 micrograms twice a day, and we increase each week if the patient is tolerating it, but it's balanced up against side effects. If they're just minor side effects, we'll just continue the current dose a little bit longer until we increase, and we push it until we've hit the ceiling, and we'll sort of try and choose a dose that they'll tolerate without significant symptoms. And there's enormous variability in the receptor sensitivity, and that doesn't necessarily mean, even if somebody can only tolerate 400 micrograms twice daily, data suggests that that they'll still have a important benefit with medication. Initially, this seems quite overwhelming, but it becomes very straightforward. It is important that you have a nurse helping, or you'll be taking lots of emails and phone calls. So usually just in a batch each week, our nurse will email us with an update about each patient and making suggestions about what we should do with doses that we'll agree or disagree. Not all units, of course, have a nurse, and the pharmaceutical company has also set up an expert nursing pathway to help liaise with you and the patient when you're at that dose titration stage. There's some other new drugs in development. Ralinepag, along the same lines as Selexipag, is looking promising, and there's some early trials that have been published recently. So Tatacept works in an entirely different way. So this is not from that figure I showed you of the three main pathways. And in short, it's quite complicated how it works, but it restores the balance between good and bad, anti-proliferative and pro-proliferative in the pulmonary vasculature. And the data, which were very recently published, were very exciting, demonstrating an important reduction in pulmonary vascular resistance with increasing doses of the drug. And many of us think that this is probably going to be the next big thing in pulmonary hypertension management. A number of years ago, it was recommended that we anticoagulate all our pulmonary hypertension patients, but as we've got much more big data, registry data, we've recognised in most of those cohorts have suggested that anticoagulation causes more harm than benefit. And so it's now not recommended that we just routinely anticoagulate all our pulmonary hypertension patients unless there's another good reason, like they've had a thromboembolic event. It was also not so long ago that we were told that patients with pulmonary hypertension shouldn't exercise, but more and more data are supporting exercise as part of one of the important strategies for us when we manage our pulmonary hypertension patients. Of course, it needs to be adequately prescribed and not high intensity, but most data have suggested that it's important at improving exercise capacity, quality of life, breathlessness, and there's possibly also a role for respiratory muscle training, especially in people who are just too weak to properly participate in an exercise training trial. And in my centre, we try and incorporate what we call pulmonary rehabilitation into our patients' routine clinical care. It's now, interestingly, a 1A recommendation in the most recent guidelines. So for a long time, left heart disease has been a very disappointing area of medicine with very little data. And this is really the only trial in recent times or ever that's shown very much benefit at all. But even then, it's shown on average a improvement in walk distance. But you can see that while there was a very large improvement for a small number of patients, the benefit was minimal or not at all for a large cohort as well. And I think part of the problem in the left heart disease research is that we're putting all the patients together. And it's very important that we try and phenotype the patients more carefully. Patients who have combined pre and post capillary pulmonary hypertension, a high pulmonary vascular resistance, and a high left atrial pressure are probably different to the patients who have a normal pulmonary vascular resistance and purely passive pulmonary hypertension. And I think that's something in the field that we really need to address. It's a big knowledge gap. A number of heart failure trials are now including implantable pulmonary artery pressure monitoring into their outcome measures, which is very exciting. I mean, how wonderful to be able to real time be assessing our patients' pulmonary artery pressure when they're out in the community and not fasting and lying on the cath lab table. And I think you'll see this being incorporated more and more, both into research and clinical practice. And a number of large units are using this as part of routine clinical care to aid patient monitoring. Particularly, some units were using it during COVID. So in conclusion, thank you for listening today. Pulmonary arterial hypertension is a progressive disease, but outcomes can be markedly improved with aggressive upfront combination therapy, ongoing risk assessment with a low threshold for triple combination therapy, and appropriately prescribed exercise training. Thank you.
Thank you, Professor Cordina, for that excellent informative lecture on very important topic. We thank you on behalf of Sri Lankan College of Cardiology for that excellent presentation. We will be concluding this session with our usual appreciation for the speaker.